I'm Matt Hoffman, an editor with NeuroiogyLive. This is the third of a special three-part multimedia series that we're doing on the metamorphosis of migraine care over the last 30 years. In the first part, featured on our NeuroiogyLive podcast, Mind Moments, we covered the explosion of pharmacologic development in migraine with Dr. Stuart Tepper, exploring the benchmark therapeutic approvals and the impact that each has had on care over the last 30 years. In part two, a feature article on our website, we examined how in contemporary care and research, the focus has shifted slightly from developing effective agents to improving the epidemiologic knowledge and understanding of the prevalence of disease, and in turn, optimizing treatment for each patient, with Dr. Richard Lipton offering his insight. Now, in this final installment in the series, we sat down with Dr. Jessica Ailani, the director of the MedStar Georgetown Headache Center and an associate professor of neurology at MedStar Georgetown University Hospital, to look at the future of care for headache disorders. She provided an in-depth look at the current clinical experience as a migraine specialist and offered insight into what's to come in the next few years as research and development continue to expand. So without further ado, here we go.
So it's been a very exciting time in the field of migraine, and I think what to me makes it the most exciting is having some new therapeutic medications and treatment options really allows us as clinicians and our patients to say, hey, this is a real disease. We have targeted treatment. We have some discussion points around those targeted treatments. And now these treatments are being discussed by primary care, by general neurologists. I have patients coming in to see me where their pain doctors, their rheumatologists, their surgeon has told them, hey, I heard there's something new in migraine. Why don't you go and talk to your headache specialist about it? And for me, that's the number one most exciting thing. Here's this disease that's always been shrouded in darkness, thought to be related to women and hysteria and, mental illness, that over time, we've been grounding ourselves in brain biology, and now we've really come to this point with targeted specific medications and treatment options that it is clearly a legitimate problem, not only to us, not only to our patients, but to all of their healthcare providers. I think the other half that's extremely exciting is having these new options. So patients who think they're doing just okay and they're getting by and there's not much else, so they'll just take it. Being told or watching on TV stories that sound very much like themselves. And then they come in and they say, I've been seeing a lot of these advertisements. I read this article in the magazine the other day. I saw a show on the news the other day, and they're talking about migraine and they're talking about this new treatment option. Is there something else I could take? And is there something that would make this even better? So it's opening up a lot of dialogue about patient disability, about the stories that they haven't been telling us even when we've been asking, because they thought, I'm doing good enough. This is probably the best I can do. I don't really need to talk about this. And so it's really been enjoyable for someone who really likes to hear my patient stories and feel like I understand where they're at, to not only hear them, but to say, hey, I actually have a whole new bag full of tricks that I can pull out and give to you that might help you without a lot of the side effects or the baggage that's come from treatments we've had in the past. Then how do we integrate that with what we've already been doing to really bring you to the best life that you could possibly need? So it's been a lot of fun.
That brings up kind of an interesting point that I don't know that I necessarily have even thought about, but just, obviously, when you talk about all these diseases in neurology, we talk about Parkinson's, some of the rare diseases, the awareness always ends up being part of the conversation, but you don't really hear a lot about, like migraine or, migraine awareness campaigns and stuff. Obviously there are some, but they may have not necessarily gotten the attention. Do you think that like the therapeutic development in recent years, and now you're mentioning, patients are seeing commercials for drugs that are now available, do you think that that's had an impact? Because I would imagine, for the numbers of the millions and millions of people who have this disease, like, are you noticing that there are patients now that like never sought care that are now seeking care because for the first time they're like, oh, I can do something about this? Like,
absolutely. When all of these new medications were coming to market, we were always getting asked, like, where do you predict things are going to go? What do you think is going to happen? And, we were predicting that we'd get people better, they'd get their lives back. Maybe some of these medications would filter down to neurology and primary care, and we would see more complex cases. But I didn't predict what actually happened. We had patients who were medication naive, never seen a specialist, never talked to anyone about their migraines, coming in for the first time because they saw an advertisement and something in the advertisement clicked with them. And they all of a sudden said, maybe this is what I've been having for all of these years, and that I kind of just chalk it up to what else could I do? I lay in bed and I deal with it. And so we're hearing all these stories of people who've been out there not seeing anybody, missing work, missing life, and just thinking this is what it was. And as sad as it is, it's also exciting because you realize, like, maybe the drug they saw on TV isn't the medicine that's the right fit for them right now, but oh my gosh, it pushed them to see somebody, to validate their symptoms, to give them a diagnosis, and to set them on a path to their better life. I think the other half of all that is, we can't ignore that when we have new medications to market, a huge amount of education has to be done to really let the healthcare providers understand when to use that medication. And that money is spent in promotional talks, but it's also spent on CME and advancing education beyond promotional talks. And so there's been a big infiltrate of money that's come into educating lots of different kinds of healthcare providers on migraine. And that has been extremely exciting to get out into the communities, to talk to people about how they've been managing migraine in their practice, to be in locations that there's not a neurologist for 600 miles, let alone a headache specialist, and be able to see the amazing care the family practitioners and the primary care doctors have been trying to piece together without having a lot of education, and now being able to give them formal talks with more tools to have, and really have that conversation about what have you been doing? That's really interesting. This is why that might be working. And what have you been doing for that? And that's interesting. Maybe you can adjust it by doing that. And so I think not only is it exciting to have these new therapeutic tools, but having more money to get more education out so that we're teaching the young, the current, and then those that are close to retirement, because the more people that understand this disease, the more they change the way they're talking to others about the disease. And to me, I think that's the best downstream effect you can have. Even if you're not going to be the one prescribing the medicine, if you're the one who talks to a family member who has had migraines all their life but thought it was a sinus issue, and you say, actually, I think that might be migraine, perhaps we should have you see somebody, huge change. You're changing that person's life, and then that changes tenfold. So I think, having medications, having devices, this is all wonderful, but having the education, that's invaluable.
Yeah, obviously, the AHS and similar societies have talked in recent years. There's a lot of talk about sort of educating, like you mentioned, the primary care doctors and these people who are, potentially going to have the only, because if you're a headache specialist, you're kind of limited to who gets referred to you. Okay. Do you think, obviously we're not there yet because there is a ton of education still to go, hopefully, I guess, sort of framing it in the context of the future, we'll get to a point where primary care providers would be able to identify these things more easily. I talk a lot with other experts about sort of the inflection point for treatment and how this is kind of like all right, now we're starting to go, we had this uphill climb, now we're starting to go downhill a little. When do you think education reaches that? Because obviously, you mentioned earlier, this was a disease that was thought to be, partly hysteria and stuff. And until, the understanding biologically doesn't really kick up until like the 90s, I guess.
Yeah. Mm-hmm.
When do you think, are we on our way toward an education inflection point about migraine? Do you think in the next decade or whatever?
Yeah, I would hope that our inflection point is just around the corner. But if you really take a look, in order to educate the volume of healthcare providers that we need to educate before we get to that, I feel like there's always a lag of about 5 to 10 years from when a major change has happened. So I take it back to, I've been in practice over a decade. And when I first started practice, as a resident, if you go all the way back, I remember in training, we didn't really see a lot of primary care doctors using prevention for migraine. And then when I started seeing patients, 4 or 5 years later on my own, I started to notice, well, actually a lot of primary care doctors were starting to use a little bit of amitriptyline and a little bit of topiramate and 25 milligrams of sumatriptan. And I wasn't seeing that 5 years back. And those medications have been out for migraine since the 90s. So you're looking at 10, 15 years until they're so comfortable. It's like a snap for everyone to write those medications. We definitely are seeing a little faster pace in education because of the internet, the amazing and horrible thing the internet is, because people can get online and watch a video at their own time or at night when they're, relaxing and wanting to learn more about a topic. We are seeing a lot more primary care providers jumping from those amitriptylines, topiramate to the monoclonal antibodies, and a lot faster uptick than I would have projected. So my hope is that perhaps that education is going to really come to that inflection in about a 5-year time period from when these new medications were released compared to a decade. So it's hard to predict, but I think we've got a little bit more of a push that we have to do to really get out into the entire community, because healthcare is so big. And I would think we've done a really awesome job when we get into the medical school and the nursing school curriculums. And that's really where we're trying to make that push. Let's get into the medical schools. Let's get more than that one lecture on headache. You get an hour to educate the entire upcoming class on headache. And what we want is like 10 hours to educate them on all the different headache disorders and how to make the diagnosis, where to turn to, what are the treatment options, and where are the changes coming. And same with nursing schools. A lot of times if you have nurse practitioner who is involved in a headache clinic. And at Georgetown for a long time, one of the directors in the nursing school was one of our nurse practitioners in the headache clinic. So she got a lot of education down into the nursing school. And you saw the difference, because when they'd become full-time nurses and if they chose to stay on at our hospital, you saw how patients were being treated very differently because they had that education early on. And that's really what we need. Okay, great, we're getting into primary care. Okay, great that people have options when they know they have to learn this stuff. But what about those that don't even think about it? If we can just get them to understand some of these basic concepts, they're going to change that conversation with the patient. And so I think we've got a little bit more work to do.
And then, of course, obviously, we're going to get to that inflection point, and then all these new targets are suddenly going to, you know what I mean? So,
then we have to redo everything. All the education has to be done again.
Completely from the beginning. But sort of speaking to that, where are we? Obviously, you and I have talked in the past a lot about sort of the biologic understanding around migraine and how, now there is this clear, understanding that CGRP plays this specific role. What are some of the other, I know PACAP is another one, but what are some of the other pathways that are sort of being explored right now that at least show promise as, we know this is at least somewhat involved?
Yeah. So PACAP is definitely one of them, but around PACAP is not just the molecule, but its receptors. So there's some early, models being done looking at the receptors that they're binding to. And so it's similar to the CGRP story. If we attack the protein and we attack the receptor, can you see benefit? And is the benefit maybe a little different depending on which you attack? They're looking at delta mu receptors for pain modulation. That makes a lot of sense because we know that mu is involved. Mu receptors are intimately involved in pain and in the endorphin pathways. So if we can alter that pathway, but in a way that might be a little bit safer, could we potentially have another target for pain and for migraine pain as well? There's something that was at the American Headache Society poster presentations this past meeting in June that I have my eye on and have had my eye on for a little bit of time. And it'll be nice if this really moves forward. And that's so early, it only has initials. I always love it when a drug has no name and it's just a whole slew of numbers because you want to get it right. But it's XC101. And this is a molecule that's looking at a dopamine serotonin type receptor. And it has some similarities to an old drug that was around a long time back, methergine and Sansert, that we've had in the past for migraine prevention, but had some negative effects. And so it had to be taken off the market in the US, that's Sansert. So we use methergine completely off-label in some patients and find it to be extremely effective. But we're using a drug that's not made for migraine, that can be expensive, that is usually used in women postpartum. And so it comes with a slew of fighting with insurance companies to get it approved. And also for our male patients, a lot of embarrassment. They'll go to the pharmacy and we have to tell the patient, you have to be ready. The pharmacist is going to say, hey, this is for women and you're a man. Does your doctor take a look at what is going on? So I think it'll be nice if we get a medicine that's more targeted, that maybe doesn't come with some of the negatives that these older meds came with, that works on a similar type pathway, which we feel is very effective in migraine. So that's, again, it's in early phases. I'm hopeful to see continued work there. And I'm very hopeful that the work will be positive and it'll move along, and that at some point we can bring that to treatment for patients. The other side of all this, you mentioned, better understanding of pathophysiology. We are getting closer and closer to having a better understanding, and we see abstracts and great papers every year that are presented that talk about, what's going on in the migraine brain. And what I really hope is at some point, we get enough information that's consistent that we can put together, that you can have training for neuroradiologists on how they can do certain imaging techniques in patients who are being referred to migraine, and they can do this protocol and come up with all of this information and identify this is not only a patient who has migraine, but they're on the cusp of chronic migraine. And even though you might see what you're seeing in clinic, there's a response in the brain that's making us concerned that they have more aggressive disease. And the same on the genetic front. We know that there's so many genes involved in migraine at a different patterns that come up, which is why migraine looks so different from patient to patient. But if there was a way we could have testing that's specific to migraine and the medications, more of the medications that we're using than that's available now, because the biggest complaint patients have is, I wish I knew what was happening in the brain and there was something that told me that, and I wish that you didn't have to experiment to find the right treatment for me. So to me, we would come a long way if I could send them for a blood test and a scan, and I get a sense that this is a person who we have to be aggressive with, or this is a person who's going to probably have 7 to 8 attacks per month the rest of their life. This one medicine is going to work. We don't have to worry about it. I think that really will change the way we're practicing clinical care. And that would also make it so much easier for your general medicine practitioner, your general neurologist, to just do this stuff without having to worry about, is this patient going to be the one that flips to refractory? And, we have to do all this other stuff. I'd really like to see that. I don't know if it'll ever happen in my lifetime, but I'm hopeful.
Yeah, I mean, it sounds, sort of similar to what you hear kind of across the board in medicine. Everyone's hopeful for this sort of
precision medicine.
Precision push, exactly. And I'm curious, obviously some, specifically in, neurologic disorders and disease, you're seeing a lot of sort of staggered steps being taken to get to that point. Some disease states are further along than others, but I'm curious, in terms of migraine, where are we at in, you mentioned testing or being able to utilize imaging in some way that would help identify these, but where are we at in terms of biomarkers? Like, have we gotten to the point where, okay, maybe we don't have the test developed or the imaging isn't where it needs to be yet, but do we at least have some sort of clue about what could potentially be a biomarker, or is that still way in its infancy?
Yeah, I actually think we're closer to having an idea of imaging than we are with biomarkers. It's unfortunate how far away we are from really understanding what's a good biomarker for migraine that can be tested in clinic. So many of us feel, and there's research to support that if you test a patient's CGRP levels, especially during a migraine, if they're high, that's an active pathway, but it's not something you can test very easily in clinic. So it kind of goes out the window as a biomarker unless you have a more stable way of testing this molecule. One project that was out for a while, the ARMOR trial, this was a registry database that was getting put together from many different headache centers where they were submitting patients to complete different types of questionnaires, but they also had a biobank. So they were submitting samples of their blood to this bank, and they were going to start to look to see if they could develop a biomarker. That's really where we need more work and more energy, more money, more funding before I think we're going to make a real wave into coming to understand what's a good, consistent biomarker. Maybe not for all of migraine, but migraine types. Like, okay, is there a good biomarker for those that have migraine with aura, with visual symptoms? Is there another biomarker for those that have nausea as their most bothersome symptom? Is there another biomarker for those that have migraine without aura that's episodic, that is photosensitive? I think patients we see clinically are really like in these buckets. And if we could figure this out a little bit better, perhaps we could then streamline treatment based on those markers. When we look at imaging, though, there's been a lot of different imaging tests looking at where's migraine coming from. And these studies go back several decades. And what we've seen in the last 5 years is they're starting to see that there's a difference in patients with migraine, and you can almost predict those that are going to have a more refractory or difficult course. at some point, there was a study by Dr. Todd Schwetz's group at Mayo in Scottsdale, Arizona, looking at like chronic migraine. So 15 days, it seems there was a change in brain functioning when you were having 15 days a month or more of headache compared to less than 15. But then in recent years, there was another MRI study that showed actually they found brain changes occurring anywhere at 3 to 4 days compared to higher. So this is what I mean by consistent. We need to kind of have everyone do the same kind of study and see, well, do you see this change if you use this technology at 15 days? Do we then see another change if we use a different technology earlier at 3 days? And where does it matter? If we image everyone who has 3 days a month of migraine, I think that's going to end up being potentially a very expensive thing to do. But if we make a decision that, hey, we need to use this technology and this is the frequency we image them at, and we're going to find information that's going to change clinical practice, I mean, that's what I'd like to see. And I'm sure we are going to get to that probably in the next 5 years, my hope.
Yeah, obviously, it's interesting because migraine, I think, is fascinating as a field just because it's like, if you look at all these disease states and where migraine was in, 1990, it's like, oh, man, we're way behind. And now just in the last, 20, 30 years, it's like extreme catch up. And now it's almost like you guys are kind of stuck in a chicken or the egg type situation. Like we need more treatments, but we need these things to develop these treatments. So we're kind of, that's what
trying to balance
these staggered steps. I'm curious, obviously outside of education and, the understanding of the pathophysiology and biology I think it's interesting that some of these agents, you mentioned things that have been around forever that are sort of being repurposed to an extent. Whether it's exploring these older therapies or finding new routes of administration, what's sort of the, quote unquote, critical need you think for patients in the next couple years? What do we need to start looking at? Obviously you mentioned, biomarker studies, but things that could potentially be done quickly, I guess.
Yeah, so I think that, the one thing that patients will often say is having options that work differently but less side effects. So if a person doesn't respond to a CGRP type therapy, the first thing they're like, well, maybe I don't have migraine. But really, no therapy is 100% for any kind of patient because the genetics are so variable in migraine. So at that point, we have some of the older medications we're leaning on, and we lean on heavy, and they come with a lot of side effects. So if we could develop mechanisms that are similar to some of the older agents without some of the side effects. So what is it about candesartan that works well for migraine? Is it because it's inhibiting ACE and that is what's playing a marker in migraine? Is there a way we could inhibit ACE without causing blood pressure changes, so it makes it hard for patients to deal with the medication? What is it about topiramate that works so well in migraine? My guess is it's because it's attacking a lot of different receptors, which unfortunately comes with that cognitive issue. But is there a way we can reformulate some of these, looking at what might be the active agent and then making it so it has less side effects? Now, I'm pretty sure if that was possible, it would have been done already. So I'm not sure we're going to get to that. But side effects are a big limiter. Sometimes patients find a treatment that works amazing, but the side effects are more disabling than the migraines itself. And that is very difficult when they walk away from treatments because of side effects. It's difficult because you feel like, oh gosh, we figured this out, but I totally would not want you living like this. So now what are we going to do? And they look to us and they're like, now what? And it's very difficult when you're like, well, we figured it out, but what you need isn't compatible with living your best life. So how are we going to find an alternative to that? And I would want more options that allows me to give them those alternatives that aren't going to cause side effects. But I think that's very difficult in a disease that has a functioning, has alterations in the central nervous system, because anytime we have to give a medicine that affects the central nervous system, there's that potential of long-term side effects. So
now, do you think that a lot of these patients, obviously, because the one thing that I think we talked earlier this year, had AHS and talked about how there wasn't a lot in terms of device development in the last year, but obviously the 3 years prior was almost nothing. Felt like nothing but devices. Do you think that, the thing these devices boast is the lack of side effects and adverse effects? Do you think that a lot of these patients that perhaps don't get the results they were expecting could or should turn to some of these devices? Do you think that potentially they're going to be used more in tandem with treatments? Because obviously more options, you'd like to think some things will be coupled at some point. But what sort of role do the devices play in all this?
So I will often use the devices in tandem, as you mentioned, and it is a good example of when we would layer something in. So either they're getting a good response, but they need more help, so a device would be a way to do that, or they're having side effects from a medicine and we need to half the dose, and then we need to layer in something to get the rest of the way with migraine prevention. But really, unfortunately, a big rate limiter for devices is cost. You know, if it's somebody who can't afford a device that's a couple of $100s per month, and even if you think the device is going to be very helpful for them, it's a very difficult scenario of, okay, let's attempt to see if we can get this approved by insurance. We often don't have a lot of great success getting it sent through the insurance route. And it's frustrating for the patients. It's frustrating for us as well. And I also think that's why a lot of times the devices aren't used in general medicine, like in a primary care office. It's overwhelming to them to tell their patient to use a device and to understand it might not be covered. And then what's the cost this month? Because the device cost can change very quickly. What's the special running? What's the website? How do I send this? Where does it get delivered? A lot of unmet needs there and questions. And I don't think it's the device company's fault. I think many times they're doing their best to, create a good device that has good evidence within the budget that they have. They try to offer discounts as much as they can, but there's definitely limitations with what they can do. I do think there are some other devices that they're thinking of coming up with or in early studies, and it'll be interesting to see how they're going to work. I know that patients will often ask us questions like, we have devices that sit at the front of the head or a device that sits on the neck. And I have patients ask me all the time, what about the device that sits here? This is where my migraine is. This is the nerve that's bothered. Or what about the device I can stick at the back of my head and just leave on for a few hours? And it's always like, well, yeah, that's interesting, but they haven't made that yet. So I definitely know this is under things that people are thinking about. And I think that that would be very successful. But then that cost issue definitely starts to play a role.
That brings up one of the last things I wanted to ask you about. Kind of prompted more by the pandemic, had been, this obviously much larger discussion about healthcare coverage in the United States. But, I spoke to Dr. Robert Shapiro about, his worries about patient access to, I finally get someone, approved to use this medication, and now we're worried about supply chains.
Yeah.
I'm curious, what do you, obviously it's a much larger discussion again about insurance and coverage, but where do you think the barrier it lies in terms of getting to a point where these patients with extraordinarily refractory disease don't have to fail? If we can identify, okay, this person will respond to this treatment,
right?
How do we get them to treat? Do you think it's partly because there is this sort of like new understanding of migraine, like we are so still early, for lack of better phrasing?
I think so. I mean, when you talk to insurance companies, they do want the right patient to get those treatments. The trouble is, there is not a standardized way of identifying who's even a headache specialist. When you talk to insurance companies, like, what is a headache specialist? What does it take to become a headache specialist? Do you have certain requirements or certifications? Is there a list of headache specialists that they don't even have the basics there. And so much of it is that, here we are in our pod trying to educate everyone. And then we sometimes forget there's another pod that needs education. So we are making really big attempts on that side to try to educate more, try to get them to understand what this disease is that does not come up on their radar quite a lot because of the barriers that are placed. So if you make it expensive to go to the emergency room, expensive to see a specialist, expensive to get a generic drug. I mean, I think that we're one of the few fields that has generics that are tiered. I didn't even know that existed before. How do you have a preferred generic over a non-preferred generic? I thought it was all the same, but it's not. And so, if they made it difficult so they don't see the blip because the cost doesn't go up, then there hasn't been the incentive to really understand. And so if we then go into that pod and start to educate insurance companies, what you start to see, which is what we're starting to see, is a little bit of okay, perhaps we will let you combine two treatments that you think are effective because it seems that we might not have understood this disease well. At least I hope that's what's going on, and it's not just because they got great discounts and so now everything's cheaper, which is also possible. But it takes a lot of work is what I'm trying to say. And that means we need a lot of people to do all of this work. And so the more we educate, the more people you're going to have to advocate to go to these companies to educate them. So then they turn around and advocate for their patients, because if they look at it, their patients, their payers, the person who's paying the payer is a company. And if the company has employees that are losing a lot of time, that's not good for the company. So the company has to say to the insurance company, hey, insurance company that I'm paying for, you must get this treatment to my 18% of my work population who are women, so they can get to work and we don't lose money. And so it's a lot of education around how do we have those conversations? How do the insurance companies understand that? How do we educate the HR departments at employment places to advocate for their employees? How do we educate our patients to advocate at their HR about their rights and to make noise about not getting treatments? It's a lot of work, but we've been seeing changes over the last year. And so I'm hopeful that all of this work that's being done by different organizations and different healthcare providers are just pushing them a little bit more so that patients are getting access to the care that they need when they are refractory, when they're at the point that even on treatment, they're still having a significant burden, to bring that burden down.
The last thing I want to ask you, and thank you again for giving me so much time. I know we're technically a little over our half hour.
It's okay.
Is just sort of broadly, sort of in summary, what do you think about your vision for the future? What are you hoping and somewhat expecting to see in these next couple of years as these things work down the pipeline, as this education, begins to, kind of ramp up? What are you hoping to see?
So my hopes for the next 5 years, for the next 10 years, is that we don't hit a steady state in migraine, that we didn't just get our boom and then it fizzles away, but that we keep creeping upwards towards better and better options for our patients so we can get to precision medicine. And from what I can see that's in the pipeline, all the research that's being done, the excitement of companies to invest in migraine and bring more products to light, I really think that this is not just going to be a boom and it fizzles out, but something that's going to keep growing. And you're going to have more excited physicians and nurse practitioners and PAs and just general nurses and basically people in healthcare that want to see patients getting better. And so that's going to keep pushing that bar forward. So that's my hope. And I think my hope is not really that far-fetched. So we'll see what keeps going.
That concludes our 3-part multimedia series on that metamorphosis of migraine care. Thank you again to Dr. Stuart Tepper, Dr. Richard Lipton, and Dr. Jessica Ailani for their excellent insight and poignant observations. And thank you for watching, listening, and reading along the entire way. For more expert-driven content just like this, head to NeuroiogyLive.com. Once again, I'm Matt Hoffman. Thanks for watching.